Okay, we will get started. Thank you for attending Northeast AHEC's Delivering Telemental Health series. I'm Michaela Titus. I'm the Director of Community Programs for Northeast South Dakota AHEC. We would like to thank you for joining us today. And Holly, if you want to go to the next slide super quick. Just want to note that we are funded by HRSA and the Aberdeen Area Community Foundation. We will be using the chat box for any questions that you would like to see addressed during the presentation, as well as at the Q&A towards the end. So if you have any questions, please let us know and we will get to them. So without any further ado, I will let Holly take over.
Thank you so much, Michaela. As she mentioned, my name is Holly Roberts. I am a licensed psychologist in Nebraska, and Nebraska is a very rural state, so we have been utilizing telehealth technology for over 10 years. So we really want to talk about some of the things we've been doing over the last 10 years that I think has become very relevant now. Especially when it comes to treatment. I'm actually at my clinic right now, so I was seeing patients this morning, and I'll be seeing them after today's presentation. So if things get noisy around here, I apologize in advance, but we're also, this is immunization season as well. I work in a primary care office when I see patients so that we can have direct access and referral stream, and also collaborate with the primary care team. But I do some in-person, but I also do telehealth. And I would say at this point, we're doing it about 50% of the time. We give families the option of doing telehealth. And some are open to that, and many of them are, but a lot of families have started to trickle back in person, where we're fully masked and distanced. And we know that as flu season is gearing up here, that the number of positive cases of COVID has increased as well. In our local university hospital, where my home base is at the University of Nebraska Medical Center, today released that they have around 150 cases, which last week at this time was closer to 70 cases, so which was an all-time high. And so now we're seeing those cases double. So I think the point of that being that we're going to be seeing a lot more telehealth being utilized especially over the winter months, as I hope through today's presentation that you'll see that this is a very helpful tool to continue to provide behavioral health services to children, adolescents, families, adults who are needing behavioral health services. So I find it a little bit easier and less distracting if you can focus on my slides and not my face or any expressions that I'm making. So I'm just going to turn off my camera, and I'm going to also keep track of the chat box as well, so that we can try to answer questions as they come in. And so I will mute my camera here. It might make it a little bit easier for me to move through the slides. Okay. So a little bit about me, and you'll have access to these slides after today's presentation. I work through the University of Nebraska Medical Center, and through that center we have the Mid-America MHTTC network. And I just have to say that I don't have any disclosures, but I can tell you a little bit about our MHTTC because it's a federally funded program through SAMHSA that allows us to provide technical assistance and training in things such as integrated care and telehealth and school-based mental health. So at the end of the session, you'll be asked to complete an evaluation and a follow-up that SAMHSA requires. It'd be really great if you could. Michaela will send that out to you. But a little bit about what the Mid-America MHTTC is. Like I mentioned, it's funded by SAMHSA, the Substance Abuse and Mental Health Services Administration. And really our goal is to provide free or low cost training across Iowa, Kansas, and Missouri, and Nebraska, where I'm based, but really nationally as well. We have 85% of our counties are designated as mental health shortage areas, profession shortage areas. So we know that improving access to care is very critical. So our goal is to try to increase access by increasing the integrated care that is provided, behavioral health infused into primary care offices to increase access to care, but also through telehealth as well, and through school-based mental health. So we're looking at I'm sure the map of the United States is pretty, it's something that everybody's seen recently with the election. I feel like I've seen the map more than I have ever. But if you look right in the center of the map, you'll see Nebraska there. And I know a lot of you are from right around this area as well, which if you're from any of the states that surround Nebraska, then you're from a primarily rural state as well. So you understand the need to increase access in various ways. So our Mid-America MHTTC housed at the University of Nebraska Medical Center, so we can provide this training and technical assistance across the country, but there are many other MHTTCs as well that provide low cost or free consultation and technical assistance and training. We have several series that we do. We invite you to look at our website. You can see that we're very much involved in pediatric integrated care and also school-based mental health. So invite you to check out our website to see the resources we have available, and our goal is to really disseminate resources that you can utilize and disseminate as well. Talked a little bit about our topics here. I'm just going to kind of breeze through so we can get started today. I enjoy talking about adolescents because it seems to be the age group that most people get a little bit nervous about working with because they tend to be a little bit impulsive. They tend to be very independent or think that they want to be independent. They tend to be somewhat moody at times and unpredictable and invincible at times. So it can be a population that becomes very difficult to understand or feel like, wow, am I making progress here? How do I move forward with my behavioral health goals? Overall, though, what we know is that mental health conditions do typically start sometime in adolescence and often go undetected or untreated, and half of those go untreated, and that suicide is the third leading cause of death among this age group, and that we have a lot of individuals in this country that are between the ages of about 10 and 19, which is where adolescence begins. So we also know that depression is one of the leading causes of illness among adolescents. So there's definitely a need for providing access to those who are trained to provide services to those in that age range. So adolescence, I looked up the definition because everybody has a little bit of a different definition. And the World Health Organization defines adolescence as a period of life with specific health and developmental needs and rights. It's also a time to develop knowledge, skills, learn to manage emotions and relationships, and acquire attributes and abilities important to assuming adult roles. So, as I mentioned earlier, it may be defined differently based on where you're at and in which society you're in at the moment. But what we know is that it's a pretty universal time period to go through, and that although it's sometimes defined by age, somewhere between 10 and 19, that although that's the most convenient way to characterize it, it's really about more biological changes. So oftentimes we see adolescents starting with the onset of puberty, which can be variable. As many of you are aware, there's physical, neurological, and psychological changes that occur, and they can occur fairly rapidly and at different times than maybe that child's same age peers. They may be going through something a little bit earlier or a little bit later, which also affects how their mood or their adjustment to daily life looks. So we have this adolescent in the middle of all of these changes that are happening around them with themselves, with their friends, with their thoughts and their hormones. And so we've got this child that is sets the perfect stage for difficulties with adjustment. Maybe it's adjustment to the pandemic and being isolated. Perhaps it's an adjustment with the physical changes or the hormonal changes in their body. Maybe it's the adjustment with some of the time that they're spending, maybe with getting into significant relationships and not spending as much time with friends. So there's many changes that are happening. So sometimes adolescence is seen as like an ongoing adjustment condition. So some of the issues that are typical during that adolescent time, wanting to have that separation from parents. I want to be my own independent person. I'm trying to figure out my role in society. I've got these sexual urges. This is a time where some risk-taking behavior occurs, and kids might dabble in a little bit of rebelliousness and think about self-harm or have a higher incidence of suicide risk versus when they were young and they didn't think about ending their life, and things rolled off their shoulders a little bit. So eating disorders start to develop around this time as well. So there are so many things that are happening which make it a perfect time for adolescents to receive care. So many, here's another list relevant to COVID-19. So school closures due to COVID-19 have meant that adolescents have been participating and learning from home, and their routines have changed, and their access to others, to social support and to teachers and to some sort of a normalcy in daily life that has changed quite a bit. And some are experiencing that as a choice, and some are experiencing this as there isn't a choice, that I have to complete courses virtually. So there's a lot of things that have occurred, and I would say that just in my practice alone, and I see kids from that anywhere from birth until about 22 is where the cutoff is. Anybody that sees one that comes in that sees a primary care provider in the clinic, and these are all pediatricians that I work with. As long as they're seeing the pediatrician, they can see me. So unless it seems like that they may need to move on to a more specialized type of care, I provide kind of that gamut of outpatient treatment. So what do we do about COVID-19 right now? How do we manage through this time? I often look for guidance in our organizations, and the AAP is what I utilize a lot. Even though I'm a psychologist, I do also look at APA and other organizations. But sometimes it's really helpful to utilize the organization that really represents your patient population, and the way that the PCPs and I communicate is through the American Academy of Pediatrics, which has great resources. And really they put out some statements about virtual guidance and what to do, because prior to the pandemic, we were concerned that our children were spending too much time virtually. And now that the pandemic's here, they're really strongly suggesting that not only do we increase access to healthcare by virtual means or telehealth, but that we allow and ensure that adolescents have internet connectivity, and that's become necessary for socialization, remote learning, employment, access to healthcare, all of these things. So really the AAP is saying, and I put this in there on purpose, with the expiration date of June 30th, 2021. So we're looking at the big picture, the long-term situation that COVID-19 has presented us, and getting ready for some more adjustments of going virtual versus in person, depending on where you live and what the climate looks like there for COVID. But closer to the bigger cities, we're seeing a lot more cases, and so we're really looking at this kind of for the long haul. We all got kind of forced into it in March, and we're able to ease back out of it, but now we're seeing that things are progressively going back to virtual, or making that shift back and forth from virtual to in-person. So I want to talk about telehealth in terms of the live synchronous audio and video. There are various types of telehealth, and often we don't think about some of the other types of telehealth and delivery. But really, I'm talking about having a session with a patient as you would in an outpatient setting, but it's occurring on a virtual platform such as Zoom. We know that if we want to look at the research on this, that patients, including that adolescent and child population, those treatments are effective, just as effective as or equivalent to in-person care, and that patients are satisfied with it. Over and over again, we've looked at, okay, there's got to be something here that virtual treatment using telehealth is not equivalent to, and we're hard pressed to find that in many situations it's just as equivalent, and as in satisfaction and in effectiveness. So as I mentioned, I'm really going to focus on the live video conferencing, the synchronous stuff, the family therapy, the individual therapy, but recall that too, that there are other forms of telehealth that are probably less often used in behavioral health, but certainly are services provided via telehealth, and in some places you're able to bill and get reimbursed for those services. And those include store and forward, transmission of like diagnostic images and vital signs along with the patient data. Obviously, oftentimes not as relevant to a behavioral health provider. And then there's remote patient monitoring, where we use devices to remotely collect and send data. Sometimes it's from a heart, sometimes it's from other devices, but it allows us to receive that information from patients in real time. And then also mobile health. So this is the type of medical and health information that includes use of the internet, wireless devices to obtain specialized health information. So just so we're clear, there are various services you can provide via telehealth, but I'm really thinking about the live video conferencing, audio video connection. So I could go into the benefits of telehealth, but I think I'm going to move past this, because I'll definitely give you resources so that we can look at this. But we know that the benefits are there, and the equivalence to in person is there, and I really want to give you an idea of what that might look like with adolescents. So let's look at that research that supports telehealth with adolescents. Let's face it, adolescents are more accustomed to technology than we are. So oftentimes they're much more comfortable with technology, and we're less comfortable. And I think making sure that we see the world through an adolescent's eyes, they typically know how to manage schools prior to the pandemic. Many children had access to a school-issued laptop or some sort of smart device or utilized them in the classroom. But what we're often seeing as well is that adolescents feel like less self-conscious when they can do when they can do a telehealth appointment. They feel like they have increased personal space. They're in a more comfortable environment, and they feel as though the confidentiality isn't as big of a concern. So even from the adolescent point of view, they're seeing the advantages associated with utilizing telehealth. And just as a little plug for telehealth, that there really aren't any studies indicating that there's a specific patient subgroup that does not benefit or is actually harmed by behavioral health visits delivered via telehealth. Typically what we see is that there may be a patient for health and safety reasons that isn't appropriate for telehealth, because we can't put the correct safety measures in place. And we're going to talk about that as we go on. But as a whole, we're not seeing that there's a certain subgroup that doesn't benefit from telehealth. So what do we do with adolescents? It's a very, very good question. And I think what it starts with is our typical procedures for telehealth apply, and our typical standard procedures for clinical care apply. What we do in person, we should mimic when we're conducting an appointment via telehealth. Now, there are going to be some additional considerations to make, but if you look at state legislation, and it may be different depending on where you're at, and I can say at the end of this we'll have links to how to access your state information. But in many states right now, they've relaxed the guidelines for delivering services via telehealth. And but a lot of states have for years have had written in the legislation, which doesn't always match the research, but it's written in the legislation that telehealth is equivalent to in-person visits. So utilizing telehealth and an audio-video connection, oftentimes we're not seeing that audio alone is covered, but right now during the pandemic, many insurance companies and states are allowing that. But I think it's really important to know that even though our state may allow relaxed regulations or even have them pre-pandemic and post-pandemic, that the insurance companies really need to reimburse for this as well. So in some states we find that yep, the law and allows us to do this, but the insurance companies won't reimburse, so we're not doing that. So really, this is a perfect time to get involved in telehealth and utilizing it with adolescent population, because in many states we still have those relaxed standards. So the same standard telehealth procedures apply with adolescents, even if they are a little more moody or they do have other they do tend to be more unpredictable and experience more adjustment concerns. So really thinking about those clinical considerations, how we're going to maintain professionalism and patient identity information, how we're going to identify whether that patient is appropriate to see via telehealth. We're going to have some sort of informed consent process that occurs. We're going to ensure that the physical environment is conducive to utilizing telehealth. We're going to make sure that we're communicating and collaborating with the referral team or the entire treatment team. We're going to have emergency management procedures in place. We're going to understand their medical issues and anything that comes along with that. And then also always having referral resources with you. I go into these considerations a little bit more thoroughly in other presentations that I've done, and I invite you to check those out through our MHTTC. You can go through them, and I can go through these things a little bit more in detail. But we also have some technical considerations that are just generally good practice with telehealth, regardless if you're seeing an adolescent. So we want to make sure you have a video conferencing application like Zoom or DoxyMe, There are others out there as well. You want to make sure that there's a device that works with these applications. If you live in a rural area or you're beaming out to a rural area, understanding the connectivity and privacy involved and connecting. Privacy has also been relaxed across the US so that you can utilize devices that may not be encrypted and so on and so forth, so that you can provide the care that you need. In many ways, this pandemic has allowed us to utilize the full extent of telehealth. I know there's always that fear that the restrictions are going to tighten things up again, and that could be, but for right now, you have a lot of leniency in how you utilize the technology right now. And I'll just put in a little plug for connectivity too. What we find is that if we are remote, providing virtual care to a family who doesn't have enough bandwidth, or the area where they live, or where they're typically receiving care isn't great, that driving somewhere like to the school or somewhere else where they may have better connectivity is always a possibility as well. I'll talk more about that in a little bit. Like I said, our legal consideration should always be there, making sure that you're qualified to provide the type of care you're going to provide. And although there isn't a universally accepted telehealth certification, that you want to make sure that you're familiar with how to utilize the technology and understand the laws in your state with regard to utilizing technology, telehealth technology, and also licensure laws in your state, what they allow. And then all of the other administrative considerations too. So all of that applies, but really the goal is that your clinical care you provide via telehealth looks as similar as possible as in-person care. So remember that equivalency. We're finding that we don't have to go out and collect all of these data points all of the time, because it's already been done for us. We've already made the case that you can provide you can provide treatment for children and adolescents with depression, whether you're in person or via telehealth. So we want to try to make that clinical care look as similar as possible. And I want to go through some modifications that we make and some considerations specifically with adolescents. So this is what you all came here for. So I wanted to get into some considerations when working with adolescents. So where are you providing care? This is maybe one of the very first things that you want to think about. Right now during the pandemic, more likely than not, you're providing care, or you've joined this presentation today because you're providing care in the patient's home. That tends to have different rules than when you're providing patient care at a patient's school or a clinic, because you have some of these emergency procedures kind of built in to these organizations. You know that there's always an adult at the school. There's always another adult at the clinic if something should happen. But really, we're talking about patients' homes here. So privacy and confidentiality is going to look a little bit different based on where we're at. So if you are at all involved in school-based mental health, or trying to find access points to see a child via telehealth with some of the relaxed laws and practices that we have right now, you may be able to see the patient wherever they're at, whether they're at home, they're at school, and it doesn't have to be a billable site. So if it seems appropriate to access the child at school, even though you're not really a school-based mental health therapist, that might provide you an access point with the child's connectivity, and you can meet with the child in a designated space that they've made private for the adolescent, and they're going to miss less school by having to leave school, go to their home. So a lot of schools have been really open to allowing a private space for that adolescent to receive care. One thing to always think about is that the difference between HIPAA and FERPA, so HIPAA being oftentimes associated with clinical settings, the Health Insurance Portability and Accountability Act, making sure that we're protecting sensitive patient health information and the flow of PHI. So who is receiving it and who is not receiving it. And then FERPA works a little bit different. The Family Educational Rights and Privacy Act, that's the federal law that protects the privacy and disclosure of student educational records. So sometimes these things get a little bit jumbled. There's an infographic by the CDC that I put a link to so that you can go see, but it covers areas such as who must comply with HIPAA or FERPA, what information is actually protected, and what are the permitted disclosures that occur. So anytime you're seeing a child and they may be in a school setting, that there are certain things that apply that are different, and you might have to utilize a little combination of both of those things. Oftentimes, if you're seeing them because of a clinical situation, or you would be seeing them typically in a clinical setting, outpatient type of setting, then HIPAA certainly applies. FERPA applies when you start getting the teachers involved as well, or if there's somebody on the other side that's involved, you certainly want to make sure that anybody you're providing information to, that you have the consent from families under both of these ideas. So services provided in the school, sometimes we want to reach out to the school counselor, the teacher, administrator, be a part of an IEP team, a 504 team, Zoom in for a meeting, not necessarily a billable service. But you also want to make sure that you are still maintaining guidelines that connect FERPA and HIPAA together. And I would say seeking out those guidelines in your state or based on your district policies in the schools would be really helpful. There are others right now who are providing billable services in the schools, school-based mental health services. And that's when FERPA and HIPAA really apply together, because this is an assumption then that you're providing that mental health, those behavioral health services within the school in person when you're not doing telehealth. So that's when those guidelines are really important. But remember, this could be just an access point for your clinical care in the schools because the connectivity might be best and the scheduling and the disruption in the child's day may be best. A lot of people have asked about group therapy. How is group therapy different? Well, group therapy, again, should be very equivalent to how you would do an in-person group therapy. So you can definitely do a telehealth group therapy. Again, I think more often than not, it's understanding the technology and feeling like you have the emergency and safety plans in place for the group and for individuals in the group prior to starting. And it definitely helps to have a co-therapist that is helping you with a group if you're doing something group-based via telehealth, because what you can do then is if there's somebody having an individual crisis, telehealth is excellent in being able to develop a breakout room so that the co-therapist could speak with somebody individually without interfering with the rest of the group and the flow with the rest of the group. So having, perhaps having another individual involved than you might typically in an in-person, and ensuring that the safety plans and group rules are set right at the beginning is really important. Having emergency contacts for everybody is always going to be really important too. And then ensuring that individuality as well. So depending on the population or the type of therapy that you're doing, whether it's individual, family, or group-based treatment with adolescents, it's definitely, telehealth is a viable option in all of those areas. It's just some considerations to make with HIPAA, FERPA, and also the makeup of the group. So what's the second thing that you might want to consider? Setting specific parameters for parent and adult involvement. And I will say that maybe I should have this with a star that's flashing here. This is really where I think the biggest consideration needs to be made. I think all of us can think of a patient right now where if there wasn't somebody in the home, we would be very concerned, or at the school, or somewhere, if a disaster would strike, if there was a crisis, if the patient told you they were going to harm themselves and hung up and were out, and you had no way of connecting with them. So I think this is really important. And what sometimes happens with telehealth is that everybody doesn't know their role or their parameters prior to. It happens after something has happened. So this is something that I would really set up, that setting the stage for parental involvement prior to that first session is really important. And we run into this in person as well. There'll be a time where I'll go out to the waiting room and the first patient comes in, and the parent has left and the child is 10. And I think to myself, what am I going to do without parent involvement here? So oftentimes this happens prior to the first session. So whenever the appointment is being made, some specific parameters for at least the parent or an adult to be present at the intake or at that first session. So set the stage for parental involvement right away. And the adult does not have to be present the entire time. What I typically set up is that I meet with the parent at the very minimum at the end of the session, and there are times where I'm going to meet with them throughout the majority of the session with the adolescent, or at the beginning and the end. But I would say if you always position that parent, I will touch base with you at the end of every single session, even if it's just to disconnect. You will be that will be the touch point. If that touch point isn't made, then the parent knows that's when we need to get a hold of one another. So having parent involvement there, even if the child is mostly independent, it just really doesn't make a lot of sense to have a child in distress at home by themselves. So outlining confidentiality, what happens if we disconnect during this, and an emergency plan occurs like at that first session. So we really know what we're going to do. So if I get disconnected from you today, whether it's because the child hung up, whether it's because the connection was lost, the internet was out, we know the procedures of reaching out, and that usually means setting up, okay, if I get disconnected from you, here's here's my number, here's your number, here's how we're going to contact each other, here's how many times I'm going to contact you. If that doesn't work, I'm going to move on to sending an email, and so on and so forth. So you kind of have this plan, but that is really something that I would suggest with anybody working on telehealth, that you have this, what happens if we get disconnected? What happens if there's an emergency? This is already all laid out prior to, but having the parent and adolescent hear all of this together can be really important, because the adolescent may have some opinions about their parent being involved. And again, their involvement may be to just be the supervising adult in the home during the session and nothing else. So set that standard with the parent. We'll meet with the behavioral health provider at the end of every session. It could to only be to say hello or goodbye, but that touching base is really really important. The next thing that is really important is private space. A lot of families that I meet with, or adolescents that I meet with, they live in an apartment, or they live in a small house, or they live in a place where there really isn't much private space. Depending on the adolescent's developmental level and the presenting concern, even though parental engagement is always recommended, there are times where we really do need to meet with the adolescent alone, and it is appropriate. And they're with the parents still somewhere in the vicinity, on location, but not necessarily in the room. And I've seen a lot of situations where you can tell that the adolescent's a little bit reluctant because somebody has entered the space that wasn't supposed to be there or wasn't scheduled to be there, or they're entering the space because they're interested to hear what's going on. So setting that expectation for private space to meet individually at the first session is really important. There may be times where I want to meet, where can we meet in your home, or where can this adolescent go to have some of that private space? And sometimes it does mean that the parent steps just right outside the door, or or sits outside for a while. I think it's really important that they feel like they have private space. Another idea would be to ensure that the adolescent has access to headphones, so that if we aren't able to create space by distancing ourselves from from the parent or the guardian, that they're able to at least have somewhat of a private conversation with the therapist. So brainstorming private space is really important, and setting that expectation right from the beginning. Little tip that I've had is that when you enter an awkward situation, and what I mean by awkward is that Uncle Larry comes over and just walks across the screen, and you're thinking, okay, that person is not on the list of who's involved in today's session. Or you see, a younger sibling or an older sibling, or again, you see the parent that's not really distancing themselves. It is important, if you have some individual time with the adolescent, that you develop a code word to indicate that the session is all of a sudden not private, because trying to read eye contact and expressions through telehealth can be sometimes kind of difficult and hard to navigate, because now it's not private, and how do we talk about it that it's not private without saying it's not private? So I've found that developing a code word allows both of us to know that the conversation or the content of the conversation needs to change at that time. And then we probably need to readdress having some privacy with the adolescent and the parent, both in the room. Interactive technology with adolescents. I'll say this again, they are better with apps and tools and virtual life, and comfortable much more than we are. So utilizing some features of your virtual platform, such as screen share, whiteboard, private chat, just as we are right now in Zoom. Use those things. I mean, sometimes you connect with an adolescent or a child to build rapport. It may not be for therapy purposes, but what you might want to, they might want to show you a cool meme that they found, or you may want to pull up the whiteboard so you can draw a picture together. Depending on how you're going to develop rapport, just utilize those virtual platform features, and have them show you some stuff. Maybe they're technologically savvy. We already know that they're much more than us typically, but also show them how to use some of the features, and get an idea of things that they've learned too, and ways that they like to communicate. Maybe they would use the chat box if somebody came into the room, and that's how they could present to you the code word through the chat, so that they don't have to say it and it seems like an odd word in the middle of a sentence without context. So utilize the technology or the platform features that you're utilizing with your telehealth clients. And then there are many apps and integrations that also work. And these aren't necessarily connected to platforms such as Zoom or DoxyMe, but they are ways of gathering data using interactive technology too. So some of the apps that are out there can be really helpful for tracking mood. Dailyo is one of them. If you're looking for mindfulness or anxiety or going through some relaxation, there are some apps out there that they can download and you can work through together. More and more as well. This has had to become a comfort thing for me as a therapist, to get into the habit of understanding that adolescents tend to text and send messages and DMs and IMs much more than they do talk to others. So there are crisis text lines that they can use if they're unwilling to. Many children, I think this is fascinating, because many adolescents that I've worked with over the years would probably be very reluctant to actually call an emergency number, and if the other parts of their safety plan aren't working, we get to that point. But they tend to be much more open when I give them the option of texting a crisis line than calling one, which again, that comes from of my comfort as well. But if they're willing to do it in a time of safety, then we need to become a little bit more comfortable doing that sort of thing. And obviously, if you have a younger adolescent or you are trying to work out a behavior contract with an adolescent and their parents, then using some behavior apps to collect these data, because if you're utilizing telehealth, you're going to be less likely to be able to provide the handouts or have them receive them, being able to print them out. There may be some apps and technology that may capture what you're wanting to do, but a little easier, and frankly, stuff that they are able to do pretty easily as well, and probably are doing in other aspects of their life too with apps. So the next thing to consider, emergency planning. So utilize standard in-session emergency planning with modifications in a home or private setting. So these are the things that we've talked about a little bit earlier. What is the plan if we're disconnected? And this is something as a therapist you can develop and then modify with each patient, kind of have a template for yourself. Here is exactly what I will do if we get disconnected, and then you can plug in the numbers or the ways that you're going to rectify that disconnection. What if the adolescent ends the session? And I think all of these things are important to know, and you might just treat that as a disconnection, because you don't know if they disconnected on purpose or not, and maybe it doesn't necessarily matter. But you also know that if the parent's not meeting with you at the end, and they know that is your cue to be able to reach out to that person, because that didn't happen, and the parent's not hearing from you, they can also be instructed to reach out to you as well. So if someone's in danger, again, you're going to have this ability to connect with the parent that is in the home, or the adult that is in the school, let's say. Or if you're beaming into another clinic somewhere, then there's a point of contact there with the clinic staff as well. So develop a form that includes some of this information. That would be a tip that I have, that I've developed as well. Again, it changes with each patient, but there are some general procedures, and some may or may not work for some of your families. So you modify them. So procedures when a call is disconnected, phone numbers to reach the patient if the session unexpectedly ends, unexpectedly, or maybe it's expectedly on their side. Location of the patient during the session, and just know where the family is at. Sometimes they are in their car. Some name and contact information of the adult that's available, phone to call for emergency services. So that's really for the therapist, having a phone available so that you can make a call while you're on that Zoom with them. And the reason why that sounds kind of like that's logical, right? It's not, because sometimes some therapists at this point are beaming in from their phone and utilizing their phone as their device to connect via telehealth. So sometimes you can't make a call while you're on Zoom. Know your state reporting guidelines. This is pretty universal. Oftentimes we think about situations of abuse, neglect, and we're able to step out of our room, talk with colleagues, whether they're the primary care team, whether there are colleagues in an outpatient behavioral health setting or inpatient behavioral health setting. Wherever you're practicing, you can run by others what you're thinking. If you're not on location, and either as a patient, you want to know your state guidelines and how to report these things without having that ability to sometimes collaborate with colleagues. Know hospitalization procedures in your state, how you get the child from one place to the other if there's refusal, and having these guidelines available to you, because again, you're not on location with colleagues that you can walk through with some of these important considerations. Number 7, risk assessment and crisis planning. This is where everybody gets a little bit nervous too, but remember, you have that parent supervising somewhere. The sessions aren't going to happen if there isn't going to be an adult around. So remember that too, and that makes following in-person procedures for risk assessment and crisis planning a little bit easier. So having that parent join at the end of every session will ensure that parents know their role in every session. And you can talk with the parent. If I just say, it was nice to see you today, goodbye, then you'll know I don't need to talk with you. If I pull you in and I'll initiate that. If you'd like to talk with me as well, and it doesn't seem that and the therapist is ending and I'm ending the session, you know, we can touch base by phone later too. So having some of that, how this communication is going to look, because oftentimes miscommunication can occur and the parent gets upset because they wanted to be a part of it, or they're upset because they are a part of it and didn't want to be. So having all of that up front, so everybody knows their role, is really important. And I'll just say the last thing is lessons learned. I mean, be kind to yourself. We're all learning to utilize this more consistently. And although we took a time in March where we all kind of made this shift to telehealth, we've learned a lot since that time. A lot has changed. And some of us were desperately hoping that things would go back to in-person. But we also know that there are going to be things that we tried and didn't work as well. So be kind to yourself. Don't give up on telehealth. It's really there to be helpful to you. But every treatment may look different virtually. But remember to keep in the back of your mind, it's effective, it's feasible. Patients are satisfied, and it's better to receive care than it's not to receive care, especially in remote areas, especially during COVID-19, where I've seen more patients that are feeling isolated and probably would have never seen somebody like me had it not been for the pandemic. So really my take-home tip here is to try to emulate in-person practice standards as much as possible when delivering behavioral health via telehealth. So in many ways, it is equivalent to in-person care. We just have to make some minute modifications. So one of those things, and I'm kind of going back to material here that is more broad that we should think about for all telehealth appointments. But I can't tell you enough. You may not be the person who schedules your patients. So having that person have access to information as to how to explain to families what telehealth is and how it's going to work for them, so that they know that the parent needs to be there at the first session. They know what to do if it's disconnected at that very first session. I mean, if we go over that in the first session and they can't connect even before the first session, it might be helpful to have an FAQ page that you can send to families that just plainly states how they're going to receive their session link, what to do, how to download the Zoom app or whatever app that you're using. And all of this could be happening during the scheduling of the appointment too. So make sure that you, before that session starts, that you've tried functions such as screen share and apps for interactions, that you're not like stumbling through even more than a lot of us already are in the middle of that session. Just really know how to use those functions. Practice with your friends, your partners, your colleagues, and do some test runs with some of that stuff too. And have your session checklist next to you. Did I go through everything that I needed to go through? And did I hit all of those considerations that are necessary or helpful when you're working with an adolescent as well? I wanted to take this time to answer some questions. I'm going to stop sharing my slides here. I'm going to bring my video back, and all of you are welcome to bring yours up as well. I wanted to see what questions you have out there. Feel free to unmute your microphone and ask. Any questions that I haven't answered?
And if you don't have a video or a microphone, you're more than welcome to put them in the chat and we'll make sure we get to them as well too.
Oh, yep, it looks like somebody had mentioned that. If you have, yes, if you have a question, please put it in the chat box. I'm happy to read it and answer it. I will take this moment too to just say, I know you're all doing a great job. As uncomfortable as this is to make that rapid shift and then to continue it and not have any idea as to when we might not have to provide care virtually. Just remember, this has been such an excellent tool. Telehealth has really increased access to patients that may not receive it. And if there's any silver lining from COVID-19 is that everybody now has this new tool of using telehealth, and that some days it doesn't feel as comfortable. Even for me, and I've been using it for years and years and years, but there are times too where I will say, wow, I really wish I could model this procedure in a way that it would make sense in person. So just know that there are even times where I don't feel like I can get that equivalent. So it looks like there are a couple questions that have come in. Do you require a parent to be involved every session with older teens after the first appointment? That is a great question. So I would say for in-person sessions, I sometimes I don't require that. And in fact, you know, it's mainly because if there was an emergency situation that came up, there are other adults in the clinic that are here that can help out. I think telehealth provides a different atmosphere because you may be beaming into a family's home, and if there isn't somebody there to help manage through, I mean, there may be some older teens with some special considerations that I would say, yeah, we may not need to, and maybe it's not the child hasn't experienced more of a safety concern. So I would say that there probably are situations where it would be appropriate to say this older teen, this 17, 18-year-old that hasn't had any history of suicidal ideation or any safety concerns, we may be able to start seeing them a little bit more independently without adult being in the same area. But I think that takes some time to really get an idea of if that's truly the case. Let's see, let me answer another one here. Would you email us the ways adolescents can text for help? Yes, I'm going to provide you a copy of the slides today, but it's literally you text you text voice or help to the number. So you put the I can't remember the number now, but the 20712 into like the 2 in your texting, and then you just text the word. So I'll send that to you, definitely. Somebody asked about what about South Dakota 211? Can people just text 211 and get an answer? I wish I could give you the answer to that, but I am not from South Dakota and I'm not quite sure if that works. I think it would be helpful to find out if there are texting options set up in your state. It says somebody's looks like Michaela's answering, simply dial 211 or text your zip code to 898211. This is really important information to have so that you have these options that are state specific. Many of the resources I gave you are not state specific, so they can patch you into more state specific guidance as well. What to do when parents are not respecting the agreement of privacy even after several discussions? This is, typically if we've had this discussion and then we meet with the family and then the child is telling me or the adolescent's telling me this isn't private, it's very uncomfortable, I'll have another discussion with the parent and typically outside of the adolescent's presence, because this is where the adolescent doesn't need to manage through adult interaction that is uncomfortable. So reaching out to that family and just providing a reason why it might be very helpful to have that individual time. That's when I might start thinking too about alternative locations. If we can meet with the child at the school, for example, if they can come out of class, the school can provide them with a private area, then I know at least for safety planning purposes, there are adults around so that there is somebody that I could get consent to consult with at the end of the session. Maybe it's a teacher or some adult that then the parent wouldn't be present at some of those visits as well. That we could find an alternative place to meet, especially if there are restrictions on how private a certain location can be. Even if the adolescent would use headphones, I feel they might not be comfortable speaking in regards to privacy. Just wondering what your thoughts are on that. And just as I said, I mean, it provides maybe an option. It may not be the answer to all privacy, but many families are pretty open to understanding that they're coming to a therapist and their involvement may not be 100% of the time. That's when I'd also reach out to others in the care team and ask about how to best work with that family or that parent. I have the luxury of working with pediatricians who know the families really well, and it's like, if I can spin this in a certain way to make this private, gather their opinions. Also, I have, like I said, fantastic pediatricians that are willing to talk to the family as well and talk to them about the importance of allowing privacy. So I think taking some of those initial steps and then trying to think about a different location to meet with the child, or possibly speaking with the parent privately, or the care team as well, seeing if there's some insight that can be gained. I know we're right at the end of our time. I do welcome you to reach out to me at any point through our MHTTC. Michaela can get you my contact information as well so that you can reach out. I'm happy to talk through all of these points of discussion, because what I'm seeing here are a whole bunch of people that are willing to at least consider seeing patients via telehealth who are adolescent age. And for that, I really appreciate it, because this is a group that really needs our help. So I appreciate you tuning in today, and I will send a copy of my slides to you, and feel free to reach out.
Thank you, and I will be ending this call. So thank you very much, Dr. Roberts.
Thank you.
Yep.
Have a good day.